Hi there, my highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So I humbly urge you to sit back and spare me part of your very precious time to share with you some very useful tips which may prove very handy in your line of duty. So I welcome you to part 92 of our pharmacotherapy MCQ series, Majoring in Basic Oncology. Welcome. So first question reads, TTK, a 36-year-old Korean American, has completed a 2-week course of Helicobacter pylori treatment and currently remains asymptomatic. She is, however, concerned of suffering from gastric cancer in future. TTK has no family history or genetic mutations for gastric cancer. So my question to you is, which of the statements listed below appropriately applies to this clinical scenario? Is it true that due to TTK's history of H. pylori infection and Asian ethnicity, we should consider upper endoscopy now and repeat annually? Or is it true that since TTK is of Asian ethnicity, we should consider upper endoscopy now and repeat every 2 to 3 years? Or is it true that considering TTK is asymptomatic and has no family history of gastric cancer, she doesn't need any screening at this time? Or is it true that due to TTK's history of H. pylori, we should consider upper endoscopy now and repeat every 2 to 3 years? I'll give you 10 seconds to choose the correct answer. So C is the correct answer. Considering TTK is asymptomatic and has no family history of gastric cancer, she doesn't need any screening at this time. Now currently, there are no consensus guidelines on screening recommendations for gastric cancer in the general population. Screening recommendations may vary based on the incidence of gastric cancer in a particular country. Now in parts of Asia where gastric cancer is more commonly diagnosed, such as for example Japan, South Korea, universal screening is performed. However, the method of screening and the interval differ between the two countries. Just like to remind you that the NCCN guidelines recommend high-risk populations for gastric cancer undergo screening with upper endoscopy. These include gastric adenomas, Lynch syndrome, juvenile polyposis syndrome, and what we call the Peutz-Jeghers syndrome, that is spelled as Peutz-Jeghers syndrome, and even familial adenomatous polyposis. Now, TKK doesn't have any of these conditions and thus doesn't require screening at all. Now, gastric cancer is often diagnosed at an advanced stage but may be detected earlier in countries such as Japan and South Korea, which have nationwide screening. So that's just a by the way. Let's move to the next question, please. And it reads, cyclophosphamide is commonly used as part of transplant preparative regimens. So So my question to you is, which of the toxicities listed below is dose limiting toxicity seen with cyclophosphamide in such clinical scenarios? Is it pulmonary fibrosis, cardiotoxicity, thrombocytopenia, or is it neutropenia? I'll give you 10 seconds to choose the correct answer. Cardiotoxicity it is. Now, cardiotoxicity is the dose-limiting toxicity seen with cyclophosphamide. I'd like to remind you that hematologic toxicities wouldn't be an issue since the patient will be receiving hematopoietic stem cell transplantation. I would like to add that pulmonary fibrosis is a possible adverse effect from such drugs like Camustin, for example, or even busulfan, not cyclophosphamide. Let's move to the next question, please. And it reads, your medical oncologist plans to initiate patient J.J.M on carboplatin and paclitaxel. The target area under the curve is 6, and J.J.M has a GFR of 75. So my question to you is, what dose of carboplatin should J.J.M receive? Should it be 700 milligrams per dose? Should it be 400 milligrams? Should it be 600 milligrams? Or should it be 500 milligrams? I'll give you 10 seconds to choose the correct answer. So 600 is the correct answer. Now, carboplatin is the only chemotherapeutic agent dosed using what we call the Calvert formula. Now, the Calvert formula is dose is equal to area under the curve times into brackets GFR plus 25 closed brackets. Now, based on the values given above, the calculated carboplatin dose for Mr. J.J.M is 6 times into brackets 75, which is the GFR, plus 25, which gives you 6 times 100, which adds up to 600 milligrams per dose. Let's move to the next question, please. And it reads, GSO, a middle-aged oncology patient, is beginning a dexamethasone regimen for delayed emesis prevention. As the oncology clinical pharmacist specialist based at the oncology clinic, what would you discuss with GSO concerning the use of dexamethasone? Would it be weight loss is a potential problem, or would it be he may experience high blood sugar, or would it be the patient may experience low blood pressure, or would you warn the patient to watch out for easy bruising? I'll give you 10 seconds to choose the correct answer. So I would warn GSO to watch out for high blood sugars. Corticosteroids are well known to stimulate hepatic gluconeogenesis, which leads to hyperglycemia. Diabetic patients need close monitoring during and after corticosteroid usage in the course of therapy. Now, the other side effects listed above may occur in cancer patients, but most likely won't be directly linked to the use of a glucocorticosteroid. Let's move to the next question, please. And it reads, your oncology team completed cytogenetics on the peripheral blood of patient HMS, and it demonstrated what we abbreviate as T into brackets 9 semicolon 22. So my question to you is, what would you expect to typically see with this chromosomal abnormality? Would it be acute promyelocytic leukemia, or would you expect plasma cell leukemia, or would you expect chronic myelogenous leukemia, or would you expect chronic lymphocytic leukemia? I'll give you 10 seconds to choose the correct answer. I would expect CML. C is the correct answer. Now with CML, the translocation of 9 and 22 allows the breakpoint cluster region, which we abbreviate as BCR gene, from chromosome 22 to be switched and fused with what we call the Abelson murine leukemia ABL, that is gene on chromosome 9. The new fusion product, which is abbreviated as BCR hyphen ABL gene, allows this tyrosine kinase to grow unrelentlessly. Let's move to the next question, please. And it reads, TBT, a middle-aged patient, recently underwent an allogeneic bone marrow transplantation and is now receiving Filgrastim as part of his treatment. My question to you is, which of the side effects listed below would you expect to occur in the course of TBT's treatment using this agent, Filgrastim? Would it be bone pain, weight loss, hypoglycemia, or hypertension? I'll give you 10 seconds to choose the correct answer. So apart from hypoglycemia, all the others are a possibility. That's to say, answers A, B, and D are all correct. I would like to start by commenting that Filgrastim, which is marketed as leukin, is a colony stimulating factor CSF, which is commonly used in oncology after bone marrow transplantation or following induction chemotherapy for ALL, acute lymphoblastic leukemia, and is associated with causing a number of side effects, which include hypertension, edema, and that edema is due to an increase in blood components. Then there is also hyperglycemia, there is bone pain, and the bone pain is due to stimulation of the bone marrow, and there is also weight loss. That's just a by the way to justify why answers A, B, and D are all correct. Let's move to the next question, please. And it reads, Mr. J.O.Z, a 43-year-old male patient, was recently diagnosed with chronic phase Philadelphia chromosome plus chronic myeloid leukemia, which we abbreviate as PH plus CML. He has a past medical history of GERD, for which he takes pantoprazole 20 milligrams once daily orally. H2 blockers and antacids don't effectively relieve Mr. J.O.Z.'s GERD, and he has found that only pantoprazole adequately controls his GERD. Your oncology team plans to initiate oral tyrosine kinase inhibitor treatment for the CML. So my question to you is, which of the agents listed below would be the best option for Mr. J.O.Z? Would it be Nilotinib 300 milligrams twice daily orally? Or would it be Bosutinib 500 milligrams once a day? Or would you opt for Imatinib 400 milligrams once a day? Or would you settle for Dasatinib 100 milligrams once daily. I'll give you 10 seconds to choose the correct answer. I would settle for imatinib, 400 milligrams once daily. Now, imatinib doesn't have the interactions with proton pump inhibitors or with H2 receptor blockers like Dasatinib, Nilotinib, and Bosutinib have, and can therefore be used alongside pantoprazole without any issues. It is an appropriate dose for first-line use, in my opinion. I would like to comment that Dasatinib, Nilotinib, and Bosutinib may have their serum concentrations decreased when co-administered with proton pump inhibitors. Package inserts recommend avoiding their concomitant use with proton pump inhibitors. And I would like to add that the Bosutinib dose for newly diagnosed chronic phase PH plus CML is 400 milligrams once daily, and the 500 milligrams once a day is only reserved for patients with resistance or intolerance to prior therapy. So that makes alternative B wrong. Now, if the patient couldn't tolerate imatinib, they could retry antacids with the other agents. If they separate the administration of the CML agents and the antacids by more than 2 hours. Now, the patients could also try H2 blockers with Nilotinib or Bosutinib if they administered the H2 blockers approximately 10 hours before or approximately 2 hours after the CML agent. So that would really be limiting and difficult to achieve, in my opinion, but it's written in literature. Now, in the case of Dasatinib, the prescribing information states we categorically avoid H2 blockers. You should avoid it completely. There is no room for maneuver. So let's move to the next question, please. And it reads, which of the factors listed below increases the risk of a patient developing breast cancer? Is it young age at first birth? Is it old age at menopause? Is it older age at the first menstrual cycle? Or is it age less than 40 years? I'll give you 10 seconds to choose the correct answer. So older age at menopause is the correct answer. Remember, patients at a higher risk of breast cancer the longer they are exposed to estrogen. Therefore, early menstruation and or late menopause will increase the risks of breast cancer. Let's move to the next question, please. And it reads, your oncology team initiates Mrs. PLG, a 35-year-old female breast cancer patient, on AC, which is doxorubicin and cyclophosphamide. For her first cycle, she prophylactically received aprepitant 125 milligrams orally as a single dose, alongside Ondansetron 0.25 milligrams IV as a single dose, and Dexamethasone 12 milligrams IV as a single dose, and on day 1 before chemotherapy, followed by aprepitant 80 milligrams orally once daily on days 2 and 3, and dexamethasone 8 milligrams orally once a day on days 2, 3, and 4. However, she is still experiencing severe nausea and vomiting 7 days after receiving her IV chemotherapy. So my question to you is, which of the treatment options listed below would be the most appropriate for Mrs. PLG now? Would it be 8 milligrams of Ondansetron orally thrice daily, or 5 milligrams of haloperidol orally every 6 hours, or dronabinol capsules 5 milligrams orally every 6 hours, or prochlorperazine 25 milligrams orally every 6 hours? I'll give you 10 seconds to choose the correct answer. I would settle for dronabinol capsules 5 milligrams orally every 6 hours. Now, the general rule for treating breakthrough nausea and vomiting is to add an agent from a different drug class to the current regimen. Thus, promethazine, haloperidol, and dronabinol are all appropriate options. However, only the dronabinol dose is listed correctly here, that is, capsules at doses between 5 to 10 milligrams, or solution at a dose of 2.1 to 4.2 milligrams per meter squared orally every 8 to 6 hours. Now, the correct oral prochlorperazine dose should be 10 milligrams orally every 6 hours, and the correct haloperidol dose for preventing nausea and vomiting in cases of breakthrough nausea and vomiting like this one should be 0.5 to 2 milligrams orally every 4 to 6 hours. That explains why B would be our best bet. I would just like to add that Ondansetron wouldn't be appropriate in this situation, as Mrs. PLG has already received a 5-HT3 antagonist, that is palonosetron, prior to chemotherapy, and is still experiencing breakthrough nausea and vomiting. Furthermore, while Ondansetron is effective for preventing acute emesis, it hasn't shown effectiveness in delayed emesis, so it wouldn't be our best bet. Let's move to the next question, please. And the next question reads, Mr. L.K.M, a 65-year-old male patient, is completing his 4th cycle of Lenalidomide and Dexamethasone. He is scheduled to undergo stem cell collection for his autologous HSCT. Your oncology team plans to administer Filgrastim to Mr. L.K.M for 4 days, followed by the stem cell collection via apheresis. So my question to you is, which of the options listed below would be the best to optimize the stem cell collection for Mr. L.K.M? Would you consider concurrent cyclophosphamide for 4 days? Would you add Plerixafor after Filgrastim? Or would you consider Filgrastim every other day for 6 days? Or would you add epoetin alpha before Filgrastim? I'll give you 10 seconds to choose the correct answer. I would add Plerixafor after Filgrastim, and I'll tell you why. Now, Plerixafor is a stem cell mobilizer and is known to disrupt binding to stromal-derived factor 1 on bone marrow stromal cells, which leads to transmigration of stem cells from the bone marrow to the peripheral blood. Therefore, the addition of Plerixafor to Filgrastim therapy will lead to an increased mobilization of stem cells to the periphery, and this will optimize, or it will help optimize, stem cell collection for hematopoietic stem cell transplantation. I'd like to add that Filgrastim every other day hasn't been studied for stem cell mobilization at all. And epoetin alpha stimulates the production of erythroid progenitor cells and doesn't have significant impact on stem cell release or production from the bone marrow. So that would be the wrong answer. Cyclophosphamide has been shown to mobilize stem cells from bone marrow, but it isn't given daily concurrently with Filgrastim. So that makes answer A wrong as well. Let's move to the next question, please. And it reads, which of the agents listed below can potentially cause interstitial lung disease? Is it the trio of Bevacizumab, Sunitinib, and Sorafenib, or is it Vandetanib, Lapatinib, and Cetuximab, or is it Erlotinib, Pazopanib, and Vemurafenib, or is it Imatinib, Dasatinib, and Nilotinib? I'll give you 10 seconds to choose the correct answer. So the trio of Vandetanib, Lapatinib, and Cetuximab is the correct answer. I would just like to remind you that Gefitinib, which is marketed as Iressa, is a tyrosine kinase inhibitor that targets EGFR. Erlotinib, which is marketed as Tarceva, is also a TKI which targets EGFR. Lapatinib, which is Ticab, is also a TKI that targets EGFR and HER2. And Vandetanib, which is marketed as Caprelsa, is also a TKI, but it targets EGFR and VEGFR. And Cetuximab, on the other hand, which is marketed as Erbitux, is a monoclonal antibody. And Panitumumab is also an MAB. Now, any agents that possesses the activity against EGFR will have a warning for pulmonary toxicity, interstitial lung disease to be specific. Now, the ILD incidence with Gefitinib and Erlotinib in lung cancer has been reported to be as high as 8%, if I remember well, in Japanese patients, compared with less than 1% in the rest of the world. It is theorized that EGFR signaling may be responsible for repair of damaged lung tissue. Therefore, using EGFR inhibitors may negatively impact or affect the pneumocyte's ability to respond to lung injury, leading to interstitial lung disease and pulmonary fibrosis. Now, ILD, interstitial lung disease, the risk factors of ILD, to be specific, were evaluated in Japanese patients who are receiving Erlotinib or Gefitinib. Now, from a multivariate analysis, poor performance status and previous pulmonary fibrosis were the two main risk factors. Let's move to the next slide, please. And it reads, TAJ presents with the CNS symptoms like severe headache, stroke-like symptoms from leukocytosis. Now, if your oncology team treated him with hydroxyurea, allopurinol, and leukophoresis, which type of leukemia is he likely to have? Is this a case of CLL, CML, ALL, or plasma cell leukemia? I'll give you 10 seconds to choose the correct answer. CML it is. Now, patients with chronic myelogenous leukemia, which is abbreviated as CML, can present with white blood cell counts over 100,000, and the blood can develop leukostasis, very dangerous indeed. Now, the patients may exhibit stroke-like symptoms because of lack of blood flow or embolus development from the viscous blood flow. Now, patients should undergo a procedure to remove the white blood cells, which is called leukapheresis. Now, tumor lysis is a potential, so allopurinol needs to be initiated along with the electrolyte management. Now, the use of hydroxyurea is needed to rapidly reduce the leukemia burden. There you have it, my highly esteemed viewers and listeners. That brings us to the end of this video. If this video benefited you in any way, I would like to humbly urge you to give it a thumbs up, to like it, and to share it widely with your peers. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the very, very best is yet to come, and I thank you all very much for viewing this video and for listening to me. I sincerely appreciate your partnership and your continued support and very kind collaboration. And I look forward to interacting with you in part 93 of our Pharmacotherapy MCQ series. Thank you very much.